السلام عليكم ورحمة الله وبركاته. I'm Muhammad Abdulwahab Ali, lecturer of surgery, gastrointestinal surgery center, Mansoura University. We'll talk today about upper gastrointestinal bleeding. By definition, upper gastrointestinal bleeding is bleeding from esophagus, stomach, or duodenum, where the source of bleeding is above ligament of Treitz. This term usually includes hematemesis, which is vomiting of bright red blood, melanemesis, which is vomiting of altered brown or black coffee ground blood, melena, which is passage of black offensive tarry stool due to action of intestinal enzymes and enteric bacteria on hemoglobin. It can be produced by as little as 20 milliliter of blood originating above ileocecal valve with intestinal transit time more than 8 hours. Occult blood in stool where bleeding is less than 20 milliliter per day, which is not detected clinically. Hematochezia, which is passage of bright red blood per rectum. It occurs in massive gastrointestinal hemorrhage, more than 2.5 liters of blood over 48 hours. The causes of upper GIT bleeding include general causes like hypertension, blood disease, hypoproteinemia, and uremia. Local causes like esophageal causes, for example, esophageal varices, esophageal cancer, esophagitis, and traumatic rupture of esophagus. Causes like chronic gastric ulcer, gastritis, gastroesophageal varices, gastric cancer, and hiatus hernia. Duodenal causes like acute duodenal ulcer, chronic duodenal ulcer, neoplasm, and diverticulitis. Causes like hemophilia and adenocarcinoma of umbilical bladder. There are also false causes like vomiting of blood ingested after bleeding from mouth, nose, and pharynx. The commonest causes of hematemesis in Egypt include esophageal varices, multiple erosive gastritis, and chronic peptic ulcer. By clinical picture, first we take history. So if we find history of bilharziasis and previous sclerotherapy, so bleeding varices is suspected. If there is history of major stress as major burn, stress ulcers are suspected. History of drug intake like ulcerogenic drugs in gastric erosions like non-steroidal anti-inflammatory drugs and oral anticoagulants. History of dyspepsia in chronic peptic ulcer. History of repeated vomiting or retching before hematemesis like in Maladouet syndrome, and history of hypertension and bleeding tendency. We search for vital signs of shock and anemia, and for general signs of the cause, like in esophageal varices, we search for signs of portal hypertension and liver cell failure, like jaundice, spider nevi, and fetal hepaticus. Major insult in erosive gastritis like major burn and uremic manifestations. For abdominal examination, we search for hepatosplenomegaly and ascites in cases with portal hypertension, epigastric tenderness in case of peptic ulcer and acute gastritis, epigastric mass or evidence of metastasis like in case of cancer. For investigation, the first and gold standard investigation is fiber optic endoscopy, which is the most valuable investigation for both diagnostic and therapeutic value. For example, we can perform electroequatory using fiber optic endoscopy, also argon beam coagulator, injection sclerotherapy, or band ligation for varices and hemoclips for bleeding ulcers or bleeding point. Its photos, the first one shows a bleeding ulcer, and here this is also a bleeding ulcer which is managed by hemoclips. This is another photo for bleeding esophageal varix, which is controlled by band ligation. Second, we can do selective celiac angiography, which has its chief indication in case of failure of endoscopy to demonstrate the bleeding site. It also has diagnostic and therapeutic value. Like in these cases, this is the shadow of the clips which failed to control the bleeding. So the catheter is introduced through the femoral artery, passed to the external iliac artery, common iliac, aorta, celiac trunk, and then to the hepatic artery, and from it we pass into the gastroduodenal artery, which is embolized here. Investigation is isotope scanning, where the patient's own RBCs are tagged with technetium 99 or chromium 51 and then injected intravenously. Abdominal scanning by a gamma camera can identify the site of bleeding. Also, laboratory investigation should be done for hemoglobin level, bleeding time, coagulation time, liver function tests for monitoring of the liver functions in cases of liver cell failure and portal hypertension, kidney function test to search for blood urea and creatinine to exclude uremia, exclude causes of generalized bleeding tendency by appropriate tests, and tests for occult blood in stool. Hematemesis usually diagnosed has differential diagnosis with hemoptysis. So the first one is the history. In hemoptysis, there is a history of chest disease, while in hematemesis there is a history of GIT disease. Hemoptysis is usually preceded by cough, while hematemesis is preceded by vomiting. Hemoptysis followed by blood-stained sputum, and hematemesis followed by melena. In hemoptysis, the blood is bright red due to oxyhemoglobin from the lung, alkaline with frothy sputum, while blood in hematemesis is dark red due to acid hematine, acidic in nature with food particles. There is also another differentiation between bleeding ulcer and bleeding esophageal varices. By history, bleeding ulcer, usually there is a history of dyspepsia which is relieved by antacids, while bleeding varices have a history of cirrhosis and jaundice. In bleeding ulcers, there is usually localized epigastric tenderness, while in bleeding varices, there is hepatosplenomegaly. By endoscopy, we can visualize the ulcer and also we can visualize the varix. The portal pressure is normal in bleeding ulcer, while there is portal hypertension in cases of bleeding varices. Sanguine Blackmore tube has no effect in bleeding ulcer, while it controls bleeding in bleeding varices. The first step treatment of upper GIT bleeding, usually resuscitation by hospitalization and absolute rest and warmth. IV fluids are administered to the patient to restore the blood volume. Fresh blood transfusion to compensate for the lost blood. Coagulants like vitamin K are administered to compensate for the coagulopathy in cases where the coagulopathy is a cause or contributing cause in the bleeding. Intravenous proton pump inhibitors are administered, prophylactic antibiotics, and a Ryle tube is inserted, which is a nasogastric tube, to assess the amount of bleeding and to irrigate the stomach with copious amounts of ice-cold saline. Central venous pressure catheter is inserted to monitor the central venous pressure to monitor our resuscitation is successful or not, and the intravascular blood volume is restored or not. Follis catheter also is introduced, so we can monitor the urine output, which is a good indicator of the circulatory volume. Observation charts are used with pulse, blood pressure, temperature, CVP, urinary output, and the amount of bleeding are monitored frequently. Usually the bleeding stops by these measures, if not specific measures are usually. And then our effort is moved to the diagnosis. When the condition of the patient becomes stabilized, diagnostic tests are carried out to determine the cause of bleeding. We consider early endoscopy within the first 24 hours, and we start the treatment according to. So, ulcer, the first step is trying to manage it using interventional treatment by endoscopic control of bleeding points using electrocautery, argon beam coagulator, adrenaline injection to cause vasoconstriction of the vessels in the base of the ulcer, and endoscopic clips. If those measures failed, selective angiography is performed, where gel foam embolization of the bleeding artery is used. Is a photo for bleeding ulcer, which is managed by hemoclips. Also, a picture that we saw previously for embolization of the gastroduodenal artery. In cases of failure of conservative treatment, whether recurrent or profuse bleeding occur, we shifted for the surgical treatment. Also, in cases with development of other complications of bleeding peptic ulcer, like perforation. What we do for the bleeding peptic ulcer, it's according to the general condition of the patient and according to the source. Cases with bad general condition, we stop the bleeding and no more. So if there is eroded extragastric vessel, we ligate the vessel outside the stomach. And in cases with bleeding from the ulcer base, gastrotomy or extended gastroduodenotomy is performed, and under running sutures. In cases with good general condition, definitive ulcer surgery is performed. So in cases of gastric ulcer, partial gastrectomy is performed, including the ulcer, with anastomosing the stomach to the remnant stomach to the intestine with anastomosis called gastrojejunostomy. And in cases of duodenal ulcer, vagotomy and drainage with direct suture to the bleeding vessel in the ulcer base is performed. In cases of bleeding, we try first endoscopic management. The first type of endoscopic management is injection sclerotherapy. We can perform intravarical injection, which causes thrombosis of the varix and obliteration of it, and then paravarical injection, which causes fibrosis in between the varices. The sclerosing agents which are used are ethanolamine oleate, 5% for esophageal varices, sodium morphate, 5% for esophageal varices, and histoacryl for gastric varices, most commonly fundic varices. These are pictures for bleeding fundic varices, and which is managed by injection of histoacryl. The second type of endoscopic management of varicose bleeding is band ligation. The idea of it is to encircle each varix by a tight band, which leads to thrombosis of the veins, then necrosis and fall down. It's effective as a sclerotherapy in the control of bleeding, but number of sessions is less than sclerotherapy. Measures to decrease portal pressure are also used, like using vasopressin, which act by decreasing portal venous pressure by causing vasoconstriction of splanchnic arterioles. The side effects of vasopressin includes abdominal colic, peripheral vasoconstriction, which causes blanching of skin, and coronary artery vasoconstriction, which may precipitate myocardial ischemia. It's contraindicated in cases with pregnancy, hypertension, and coronary diseases. Second type is glipressin, which is synthetic vasopressin analog. It has a longer action and have fewer side effects, but more expensive. The third type is somatostatin, which decreases pressure inside the varices, and it's also very expensive. Octreotide is a synthetic somatostatin, which is given subcutaneously. In case of failure of above measures, surgical management is recommended, which is discussed in cases in the lectures of portal hypertension. Thank you.